On track and on time, as symposiums are often want for running over time and running late. I'm Professor Raymond Koo. I'm going to be the moderator, which in this case isn't a whole lot of work for our panel this afternoon on legal, medical, or policy solutions for ending healthcare disparities caused by racial bias. It's my pleasure to introduce, in alphabetical order, Dr. Sana Liu, who is a professor and director of the Department of Bioethics, Psychiatry, and Global Health, and the former director of the Center for Minority Public Health of the School of Medicine at Case Western Reserve. She has secondary appointments in the Department of Epidemiology and Biostatistics, and is Vice Dean for Faculty Development and Diversity. David Miller is currently an associate professor at the Mandel School of Applied Sciences at Case Western. Dr. Miller received his PhD and Master's of Public Health from the University of Pittsburgh and his Master of Social Work from the University of South Carolina. Dr. Miller's current research focuses on the health status of African American males. And one interesting note, he not only teaches courses in both the master's and doctoral programs, he currently serves as the councilman at large and president of City Council in South Euclid. Dr. Alan Sager is Dr. Alan Sager is professor of health policy and management at the Boston University School of Public Health. He holds a BA in economics from Brandeis and a PhD in city and regional planning from MIT. His main interests are health reform, combining universal coverage with cost control, improving both finance and delivery, and preserving needed physicians, hospital, and long-term care services. He has studied causes and effects of urban hospital closings, finding a strong and persistent link between race of the people living near a hospital and the probability of closing. Lastly, but not least, Dr. Ashwani Shaigal is the Duncan Newhouser Professor of Community Health Improvement and Director of the Center for Reducing Health Disparities and Professor of Medicine, Biomedical Ethics, and Epidemiology and Biostatistics at Case Western. In addition, he's a practicing nephrologist at Metro Health Medical Center. Dr. Sehgal received his bachelor's degree in mathematics, summa cum laude, from the University of Rochester, and his MD degree from Harvard Medical School. His research is focused on quality improvement and health disparities. Well, please join me in welcoming our panelists.
Good afternoon. Can everyone hear me okay? Is this working? Okay. Just a quick correction. I don't direct the Department of Bioethics. And to give you some sense of the lens through which I see the world, my professional training is in social work, in law, in medical anthropology, in theology, and secondary education. So this is my filter through which I see the world. We've talked a lot about health disparities. The term is used interchangeably with health inequalities, health inequities, and we know that disparities exist even when controlling for other factors. One of the speakers this morning, when he was talking about bias, said, bias can be in favor of something or against something, and the same is true of disparities. So when we look at health disparities, it may mean that one group is getting less of something that they should be getting more of, but another group may be overutilizing something or getting more of something than is really necessary. So I think that's important to keep in mind. Just as a quick refresher, we know that there are disparities in access to care. For instance, we know that a significantly smaller proportion of Latinos and African Americans have a usual source of care compared to non-Hispanic whites, that disease risk is significantly higher for minority groups, and some examples are diabetes, and that African Americans and Latinos have significantly less access to important forms of treatments, such as with HIV and certainly with mental health care, which is one of my areas. There are system and provider factors associated with disparities, and I'm going to be talking more about provider level and system level factors, but just to give you sort of an overview, organization, financing, and delivery of healthcare has an impact on disparities. Provider level factors, age, sex, stereotypes, bias, communication barriers, cultural differences, training, specialty, clinical experience, the form of compensation and performance expectations, decision-making, which we've heard a lot about in this symposium, and even hospital characteristics have an impact. There are also patient-related factors: insurance status, income level, limited English proficiency, race, ethnicity, sex, sexual orientation, immigration status, and stereotypes and bias. So patients also come with stereotypes and bias. We've heard from a number of speakers that cultural competence hasn't fulfilled the promise that it sort of introduced. And I'm actually going to focus on why that is the case and what we can be doing in place of that. So the idea behind cultural competence was that it would provide a knowledge base about different groups with identifiable characteristics, that it was a mechanism through which individuals could then monitor their own biases, their own explicit biases and behaviors, and that somehow through the acquisition of this knowledge, individuals would become more sensitive to and understanding of people from diverse groups. And the idea behind cultural competence was that somehow people could master this body of knowledge. It was a finite point and quantifiable. So if we look at this picture with the German shepherds and the kitten, I would suggest that very often this is how patients feel when they walk into a healthcare establishment and are confronted by an array of healthcare professionals. But I would also suggest that very often this is how healthcare providers feel when meeting individuals who are patients and colleagues and students who don't look like they look. It's like, what do I do now? So we know that when we have labels for people, when we have categories, that, and this has been mentioned in other presentations, that these are basically social constructs that we make to somehow organize the world. And we do this across domains, not only with people. However, the process of categorizing people is really the effectuation of power. So those who have the power are the people or the groups who are able to categorize and label other individuals. If we look, for instance, at how African Americans have been classified throughout US history, you find that who was defined as black has changed over time. The rules for that have changed over time. If you look at court decisions to see how Asians were classified, you find that in the 1800s there were court decisions in the South that classified Asians as black, and as a result they were prohibited from owning property. If you look at the court decisions that came out of California, they were classified as white and could own property in certain locales. So all of this tells us that how we construct and impose categories, in fact, is an exercise in power that has the ability to impact everything that comes after that. So when we look at cultural competence as an approach to dealing with disparities, because this is one of the reasons we promoted cultural competence, it often assumes that it results from individual ignorance, but it doesn't consider systemic issues. The promise of mastery, I would argue, is a false promise. Through cultural competence, it fails to account for changes in culture over time. And culture moves at different rates. So for instance, there's cultural change at the societal level, at the community level, at the group level, and at the individual level. If you conceive of your individual culture as sort of like a shopping cart that you are handed at birth through your family, through your neighborhood, through your community, as you move through life, you may decide to discard something in your shopping cart and substitute something else. But it doesn't mean, that doesn't tell you what's happening to the culture of the grocery store in which you have that cart, right? So you're seeing culture change at multiple levels. It doesn't, the idea of cultural competence doesn't consider the interaction and mutual evolution of subcultures and majority culture and how those are defined. And I would argue that what in fact it does is reify stereotypes. What it does is simply substitute one stereotype for another stereotype. So instead of seeing the stereotype that certainly prevailed when I was growing up of Sambo. There was a book called Sambo. We now have a stereotype that African Americans do this, Latinos do this, and if someone in front of you can be identified through your own lens as falling into that category, well, then you apply these characteristics to them, and that tells you how you should interact with them. It also assumes that diversity and an acceptable interaction is an issue only when a non-Hispanic white encounters someone who is non-white. And in fact, we know that's not true. There's a body of literature, for instance, around microaggressions that suggests that individuals of one minority group can be equally insensitive to those of another minority group as non-Hispanic whites can be. It fails to consider all salient factors and assumes that a member of an identified group, by virtue of being a member of that group, is necessarily culturally competent, again, because it fails to account for multiple variables at the same time, including educational level, social class, and any number of variables. Cultural competence focuses on the acquisition and mastery of a finite body of knowledge. And again, those who say what that finite body of knowledge is and should be are those who have the power to do that. And by promoting categorization and labeling, we don't consider intersectionality, which was raised as an issue this morning. And I would argue that by failing to consider intersectionality, we are in fact exacerbating marginality and disempowerment. And I don't know if you can read the writing at the bottom of the slide, but it says ethnic origin, put me down as mixed race. So I would argue that what we need to do is to reframe cultural competence and instead work from a foundation of cultural humility. And cultural humility is the underlying assumption is that in each and every interaction, there's something that we do not know and understand. So rather than seeing an individual and saying, oh, this person looks like X to me, and therefore I can go down my laundry list of characteristics and respond to them as if they are an owner of those characteristics, in meeting that person, I have to assume there's something about them that I don't know, and that only by creating a safe space of respect and exchange will I ever know that. It focuses on the development of critical consciousness to change attitudes as well as explicit behaviors. And what is key to cultural humility is that it requires lifelong learning and critical self-reflection. There is no endpoint. The endpoint is death. Learning is to be transformative rather than simply informative, and it requires an active engagement with the people with whom we are interacting and with the world around us. What the actual implementation, the effectuation of cultural humility does is to change power imbalances and to realign the power relationship in each and every encounter. So if we compare cultural competence and cultural humility, whereas cultural competence is viewed as a discrete endpoint, cultural humility is a process. Whereas cultural competence focuses on substantive content, cultural humility is process-oriented, requiring self-reflection and critique. Cultural competence merely informs. Cultural humility has the potential to actually transform us as individuals and as groups and systems relating to each other. Instead of a false sense of knowing, we continue to have a sense of curiosity, a sense of wonderment, and a sense of openness. And it acknowledges each person who is participating in this interaction as a co-learner. So I'm going to close with some quotes from Dr. Seuss. You are you, and that is true. There's no one in the world who's youer than you. It is better to know how to learn than to know. And this is an individual in all of his multiple identities. Thank you.
is afternoon, so I'll say good afternoon to everyone. And I hope everyone can hear me okay. We'll try to speak into the mic as best I can. It's kind of hard to follow Dr. Seuss, so thank you very much. It's like, okay, doctor, you just want to go. My name is David Miller. I'm a faculty member at at Jack, Joseph, and Morton Mandel School of Applied Social Sciences, as you can see on the slide here. I'm also standing before you pretty clear. I'm a person who likes to visit, or used to like to visit, the barbershop. And so I haven't been to a barbershop in about 11 years. So when Ash said he hadn't seen me in a while, it's been a long time. So make sure if you don't see people, go check them out, because a lot of things can change in their multiple areas. What I'm going to talk about today, briefly, are the social determinants of health and the influence on African American males. It's an area that is very important to me, not because I am an African American male, but it's an area that's important because my health affects her health, affects your health, affects all of our health. And we must look at it. One of the things I have talked to individuals about, we've had healthy people 2000, we've had healthy people 2010, we've got healthy people 2020, and more than likely, we're going to have healthy people 20, 30, 40, 50. Hopefully, we'll get to a place in our society, as Ms. Boyd said, where we won't have to have a conversation about changing health goals into the future, that we will get serious about our health, that we will do something about something that affects so many people in this country, and that, as the gentleman did point out, it is a significant part of our economy, and we must address that issue as well. Health disparities. I'm sorry to repeat probably a definition that has been given, but I wanted to at least highlight that it's the results of a chain of events evidenced by a difference in one's environment, access to utilization of and quality of care, health status, or a particular health outcome that deserves scrutiny. That's one way to look at health disparities. It's also, or could be, looked at continual accumulation of unfavorable events affecting people's health that are connected to their broader social context. We play a game at MSAS when we're in the hall, and it's, what drug are you on? And some folks are on Celebrex. Some folks are on something else, and they get to me and say, well, what drug are you on? And some people kind of look behind and say, yeah, we know what drug you're on. I say, no, and I'll here, take a cup, we can figure that out too. But when I tell them that I take no medication at all, they look at me like, you're a black man. You don't have hypertension. You don't have diabetes. You don't have nothing. No. It's as if, again, with Dr. Seuss, I have two heads. But when we look at individuals and expect them to have a condition because they are black, because they're female, we need to step back and look at ourselves, because that helps perpetuate some disparities. When we look at the term health disparities, there are multiple definitions, and some definitions simply focus on the differences, but on inequalities, but there are also inequalities or inequities in health, the differences which are unnecessary and unavoidable, but in addition are also considered unfair and unjust. Social context is very important. That's the crux of my talk here, is that it includes a wide range of individual, cultural, and socioeconomic and political factors that influence health outcomes. These factors include individual constitutional and lifestyle factors. I joke with people, I was supposed to get up this morning and go spin at 6 o'clock, and folks say, you get up at 6 o'clock in the morning? I really get up at 5:15 so that I can be there at 6 o'clock, because it's very important. We have to do it. We have to take time for our health. It's also family and social relationships, housing, neighborhood, environmental and occupational conditions, societal expressions of discrimination and opportunity, and the access to and quality of healthcare settings. All that goes into the makings of health disparities. This was a slide that was developed last night. We were talking African American men's health. Duh. It's just, when you look at us, African American males, Latino males, Asian males, as a group, our health is poor. And I challenge anyone who can say that this statement is not in fact true. That in the history of the United States, no other group, save American Indian and Alaska Native males, has experienced and continues to experience more barriers to health and welfare than African American men. But when we talk about health disparities, frequently we talk about behavior, not exercise, not eating right, not getting out, doing some things. But we don't talk as much about the social and environmental factors. Yet those factors place African American men at significant disadvantage with regard to health and disease. African American men are exposed to numerous difficult life experiences, reduced access to quality education, reduced access to employment, disproportionate rates of incarceration. I used to work in a prison, and I joke with folks who don't know me, and they say, well, what did you do? I said, I was in prison. And again, black man, dreadlock, saying you're in prison, you can see it in their face. But then I said, well, I worked in a prison for 2 years, 30 days, 8 hours. And while there, I saw a lot of young men, many of them poor, many of them African American. And from time to time, I go back and look at individuals in the state of South Carolina. When they say you have a 30-year life, you have a 30-year life sentence. 30 years, 3 decades, however you want to make it, day for day. And I saw individuals who went in at 25 and who are now in their 50s and they look like they're in their 70s, who are beaten down by the stress. And I'll talk about that later, but the incarceration, the lack of education. African American men are among the most underserved populations in the United States with regard to access to quality health services and mental health services. Health behavior alone, though, does not fully explain the significant health disparities among African American men. Again, I'm sure you've seen these numbers in some way. Put in a different, more succinct manner, if it's good health, black men are on the bottom, and if it's bad health, black men are on the top. We can keep it real simple. We also, I've heard in the conversations the usual suspects: hypertension, cardiovascular disease. But I wanted to introduce one today: oral health. Because it's something that we really don't consider or we don't talk about. But here in the state of Ohio, just looking at some data, we have some significant oral health problems in this state that need to be addressed. When we talk about the social determinants of health, low socioeconomic status, racial discrimination, incarceration, and racial residential segregation. These are all factors that contribute to health disparities that we oftentimes don't look at or don't receive a lot of attention in the research literature. And something that I am asking my colleagues, and I'm asking you in the community also to look at, to talk about, to raise. I can't speak for the attorneys in the room, definitely won't speak for the physicians in the room, but for the rest of us, these are some areas that we can look at, that we can talk about. And the attorneys and physicians can spend some time as well investigating these and their impact on the health of all groups, not just African American males, but all groups. And these factors link together. 25% of African Americans live below the poverty line. I checked this yesterday, just to be sure. For white males, what their earning rate, and for those in statistics, they would be the reference group, right, Sonny? The white males, their pay. African American men earn 75% of what white men earn. The latest unemployment statistics, seasonally adjusted, show that nearly 13% of African American men are unemployed in February 2014 versus 5.5% of white males, February 14. It's latest statistics, not mine. African American males more likely to live in urban, economically disadvantaged areas with poor neighborhood conditions and environmental hazards. One of the panelists is going to talk about the lack of hospitals. These factors all go in together to help create and perpetuate some of the disparities that we see. Racial discrimination, individual and institutionalized. It's here. And I'm not going to beat that horse to death. We know it's here, we know it still exists. But it manifests in three areas that affect health: quality education, access to employment, and again, incarceration. There is a link. Existing literature shows the effects of environmental adversity on weathering the body that emphasizes chronic stress. A part of my research is around chronic stress, and stress does affect the body in very negative ways, leading to inflammation and other conditions which contribute to some of these high factors and incidents that we know to be true, and this develops over time. Incarceration. African American males are six more times likely to be incarcerated than white males. The rate is 4,347 per 100,000 versus 678 per 100,000. You're in prison, you're highly stressed. You come out, no one's going to hire you. Inadequate access to housing, health services, unemployment, all play a role in the continuance of health disparities and of the health conditions that we see. Excuse me. I always hit the wrong. Technology never fails. Oral health. We don't talk about that. Being a social worker, individual self-esteem is oftentimes tied up in their appearance. And it's what we used to say as kids, you got yuck mouth. Those individuals aren't going to go and seek employment. They're not going to interact often with folks. Here in the state of Ohio, the data that I'm looking at currently shows that individuals who report fewer visits to the dentist also report poor health, physical and mental health. So there is a connection with that. Prostate cancer awareness, and my time is wrapping up here, but an area of research that I look at, we need to increase the understanding and awareness among young men of prostate cancer screening, the treatments, also to be involved with their physicians regarding informed decision making. We've got to start it early. I won't get into the controversy about screening versus not screening. I come down on the side, we should have screening. But where do we go now? Focus on education, prevention, and awareness early. It needs to start not when we're in our 30s and 40s, but with our children in school. We need to improve health literacy, environmental enhancements. You can't exercise if your neighborhood is a shooting zone. We need to have community collaboration and research. No more parachute research. We come in from Case, from Michigan, from Johns Hopkins, from wherever, do the research, get the numbers, and get out. We need to take that back and do something in the community. We need to understand our family health history and also complete a family health genogram. Know what Uncle Joe died of. Know if grandmother had diabetes. We need to have that information ready to share with our physicians. We need to have that information ready to share with our family members. And we also need to acknowledge the historical legacy of discrimination on health. Cornel West once said, and as a social worker, I agree, you can't treat the problem until you first say you have a problem. So we have to acknowledge what the past and present has done. And then once we acknowledge it, I think we can make headway on making Healthy People 2020 be the last report or focus of that nature. Thank you very much.
Good afternoon, and thank you for inviting me. Where I work, we teach for 3 hours at a time, so that's become my unit of thought. You don't mind. The problem is we don't have that much. Do you have a sign for 2 hours and one? In the interest of time, the jokes have to go. That was the joke. Thank you. Okay. Which one is health, which one is education, which one is defense in 2010? Number one, of course, is health, education. Number two is health. Number four is? Well, you're 0 for 3. Number one is defense. Number two is education. And since we've lost degrees of freedom, number 4 is health. So U.S. healthcare spending, $3.1 trillion this year, $9,200 per American, is enough to provide the care that works to everybody who needs it. I'm not saying any of the numbers is right or wrong, but this is the reality. There is the money. Bottom line, I've looked at 1,200 hospitals in 52 cities for 75 years. And by the way, I'd like to thank Dr. Newhouser at Case, who got me started on this in the early 1970s by assigning in a course he was teaching in a non-Cleveland university at the time, called the Urban Community Hospital in Transition. What predicts hospital survival? Never efficiency. There's no functioning free market. The race of people living near the hospital consistently predicts survival. Hospital size and teaching status consistently predict survival. Cumulative effect of hospital closings and other changes. Harms access, boosts cost, mixed effect on quality. We lose needed hospitals and we lose the doctors who work at those hospitals. The two losses are mutually reinforcing. Hospitals and doctors are not alternatives, they're complements. We need them both. We need legal, financial, and political remedies, and they are available. Which hospitals are likely to close? Looked at 52 cities, those are them. Please take notes, this will be on the final. The cities match the density of population. This is their share of beds and people over time, up to about 1/3 of the beds and 1/4 of the people. Their share of the U.S. population has been dropping over time. These are the older cities by and large, some growing ones like San Jose. At one time, these cities housed almost half of the U.S. black population, down to about 28% of the African American population. Number of hospitals in these cities peaked in 1970, dropped substantially to 210. Beds per 1,000 people rose, but by 2010, on the right, their beds per population and the U.S. beds per 1,000 people are 1 bed per 1,000 below 1940 levels. Okay. Beds by medical school affiliation. What we see is the ones with the fossils on them, the dead fish, those are the ordinary 100, 200 bed community hospitals. As a share of beds, they're over half in 1950. They're down below 1/4 in 2010. The picture of the fossil, by the way, is from Fossil Butte, southwestern Wyoming. your property, you can go there for free and take fossils, because there are millions and they don't want them. Teaching hospitals, clearly growing as a share of urban beds. Consequences for quality, also for cost. Do rich hospitals deserve to be rich? Rich hospitals have lots of privately insured patients. They think they're doing a better job. They engage in self-sanctification. We're rich, we survive, therefore we're doing God's work on earth, and the free market anoints us with success. Really not so much the case. Poor hospitals are located in areas with lots of Medicaid and uninsured patients in African American neighborhoods, serving unprofitable diagnoses, vanishing doctors in private practice, sometimes perceived low quality, sometimes real quality problems, less power, and they blame themselves. Hospital profitability varies enormously even by state. Hawaii on the left, losing money. Utah on the right, consistently the most profitable year after year. These are not caused by real-world forces. There are reasons. This slide shows efficiency of hospital by medical school affiliation and survival. What this shows is that there's really very little correlation between efficiency of the hospital and its chance of surviving. And separate pairs of bars for teaching, minor teaching, and for non-teaching, minor teaching, and major teaching hospitals. Generally, the hospitals that closed were actually more efficient at the start of the period by a tiny margin, not significant. In a functioning free market, we know that the efficient hospitals would be more likely to survive because they'd have lower cost, lower prices, and would attract more patients. Anybody know what that is? Ebbets Field. Brooklyn Dodgers went to Los Angeles. Turns out, Major League Baseball teams leave the same neighborhoods that hospitals leave. It's not attendance, it's not place in the standings, measures of finances, it's not age of the stadium, it's the race of the residents living nearby. Brooklyn hospitals closed. The wrong team left town, but that's a Boston, we won't go there. Race, on the other hand, unlike efficiency, consistently predicts survival. When we're predicting survival, the number of beds, the accumulated wealth of the hospital, fund balance, occupancy rate, area percent black, number of hospitals nearby, all affect survival. More beds, more wealth, more patients, more black people, bigger chance of closing. Sorry, more beds, more wealth, higher occupancy rate, bigger chance of surviving, more African Americans in nearby community, greater chance of closing. This table, in the upper left-hand corner, where we have 5% black and a 600-bed hospital, has a 6.1% chance of closing. Yeah, right there. Here's a 100-bed hospital in a 99% black community, 72% chance of closing. This comes out of the logistic regression analysis. The model is highly significant, and it does predict closings accurately. So what? The health care we get depends heavily on the caregivers we've got. But aren't patients just voting with their feet to avoid low-quality or unresponsive hospitals? Can a hospital really be needed if it's losing money? Do we really need many hospitals? Won't community health centers substitute? They're a complement, but not a substitute. Won't we live forever if we just lose some more weight? By the way, healthcare has never saved a single life. It's worth appreciating that. That's more of a theological or philosophical question, I think we'd agree. What healthcare does is delay preventable death, overcome pain and disability, and give us medical security, which is confidence that we will get needed, competent, and timely care without having to worry about the bill or about being bankrupted by getting care. Growing medical wastelands. Almost half of the hospitals opened in 1970 had closed by 2010. More than 60% closed in areas heavily black. And we'll look at St. Louis, Detroit, Washington, Cleveland, Brooklyn. There's a great risk in putting too many beds in too few baskets in too few hospitals. Katrina in New Orleans, Sandy in Manhattan, all meant a grievous disruption of care, disaster planning. 30% of patients are displaced by a closing. They just stop seeking care. Nationally, blacks relied on hospitals 2 times as heavily as whites for doctor visits. In the outpatient department or in the emergency room, you lose the hospital, you don't just lose the inpatient capacity, you lose the doctor capacity. Now, it's not the best medical care. Continuity of care, forget it. But what you're talking about is a place to go. It's not the best, but we want to keep what's barely adequate until we get something better. Just because it isn't the best isn't a reason to throw it out without a better substitute. The French have a saying, the best can be the enemy of the good. St. Louis. All the hospitals in the northern half of St. Louis are gone, including 2 or 3 public hospitals, which is the African American half of St. Louis. Detroit, 42 hospitals in 1960, 4 sites of care survive, all of them major teaching hospitals, no inexpensive care in Detroit, and half of the beds are owned by Vanguard, now Tenet. Will they keep them open? That's 132 square miles. They do not plow the side streets in the winter, and increasingly they do not plow the main streets in the winter. 4 hospitals for a city that big is not acceptable. 4 emergency rooms in a city that big is not acceptable. Washington, D.C., there's 1 hospital left in the lower right-hand corner in the eastern half of the city after the closing of D.C. General. That hospital is not a good hospital. It occasionally kills people. It's under city control now because the city had to bail it out to prevent it from closing after the city allowed D.C. General to close. Cleveland, we've got University and, as you know, Cleveland University and Cleveland Clinic left. On the east side, everything else is closed, including Huron Road, which is outside the city. So there are patterns. Brooklyn, same thing. And also, the bed-to-population ratio in Brooklyn and nearby Queens is plummeting. And ambulances don't like to go into Manhattan because they can't get back in rush hour. So there are grievous consequences unfolding. And some people say, well, we've got too many hospitals and too many beds, no matter how few hospitals we have left. And they will close the hospitals without ensuring substitutes like real primary care are available. From the cost standpoint, fewer hospitals mean fewer competitors, less price competition, higher revenue for surviving hospitals, and that simply allows them to spend more money to care for the patients they serve in the style they like to remain accustomed to. There's a slight tendency decade after decade for the more expensive hospitals to remain open and the less efficient, and for the more efficient hospitals, the less expensive hospitals, to close. Teaching hospitals have a bigger and bigger share of hospital beds over time. Consequently, our lower-income urban patients rely more and more heavily on the world's costliest teaching hospitals. That puts much cost pressure on Medicaid, makes it harder for us to sustain care, especially as Medicaid, under state governments, pays lower and lower prices. Now, on the quality side, were many of the closed hospitals effectively segregated racially and unequal in quality? That has been often the case, but certainly not always. Closing of heavily black non-teaching hospitals and relocation of their patients to large urban teaching hospitals might be thought of as giving us more integrated mainstream care and boosting quality. But do patients with routine problems get good care at large teaching hospitals that are more interested in complex problems at the frontiers of medicine? And is care at integrated teaching hospitals racially neutral? Is care at integrated teaching hospitals integrated? Or is there still a separate floor for Medicaid patients, as a hospital in St. Louis notoriously had for a number of years? There's mixed evidence, and the patterns of care are probably mixed. But what we've often done has been to move the problem and shift its site from the hospitals that closed to the hospitals that survived. But if you haven't got a doctor in private practice and attending to advocate for you, it's harder to get the right care. And if your problems are a compound leg fracture or appendectomy and so on, you're a boring problem. Pneumonia, you're a boring problem. The residents and the nurses tend to pay less attention to you in a major teaching hospital, where it's also harder to sleep through the night. We need to stabilize needed hospitals. Without a free market to weed out inefficient hospitals, and with a racial link to closings that's more than troubling, and with looming bed shortages in many areas, as urban populations age, there will be a need for 30, 40% more beds. And with the cost of replacing closed hospitals over $1 million per bed in many cities, and $2 or $3 million per bed in LA County, which rebuilt its main county teaching hospital with too few beds. It's going to cost us $2 or $3 billion for every 1,000 beds we have to replace. A hospital today is worth more than promises tomorrow, especially when a hospital's survival depends on organizing needed care for patients who have no alternatives. Also, we have to shift the burden of proof. With so many hospitals gone, no hospital should be allowed to close without proof that it's no longer needed to protect the health of the public. Action steps. First, we have to identify needed hospitals likely to close. Which hospitals and emergency rooms are essential to protect the health of the public, today and tomorrow? Only one state out of 50 has a list of hospitals and emergency rooms that are needed to protect the health of the public. And they're required by law to have that list. It's state of Maryland, which has a legal obligation to pay needed hospitals money sufficient to cover the cost of efficiently provided needed care. The other 49 states are clueless. And they can allow hospitals to close because they don't know if they're needed. A little twitch, we call that policy by spasm. Hospitals running out of money, local government financial crisis, state government crisis, you close St. Vincent in Lower Manhattan. We need a list. We have to identify hospitals that are likely to close in time to intervene. We have to make the public aware of the risk to needed hospitals, which trustees and CEOs often deny. That will be embarrassed if somebody else saves the hospital when we couldn't. Another action step, we need hospital receivership laws to allow officials and citizens to petition a court to take control of the hospital and stabilize it. Governors have to be urged to declare public health emergencies, allowing the state to take control of a needed but bankrupting hospital. We need money to back up those legal steps. A 1/4 of 1% assessment on all hospitals' revenue would generate $500 million a year in a revolving trust fund to protect needed hospitals. But at the end, we need to guarantee each needed hospital revenue to cover the cost of care. Maryland has a state-run all-payer system which provides revenue to every hospital that's needed, as long as it's reasonably efficient. All payers pay the same price, just like we'd have in a functioning free market. The money is there, $3.1 trillion. Write it out. Write out that number, please, with all the zeros. Don't use trillion. The money's there. The care we get depends heavily on the caregivers we've got. If our hospitals continue to become bigger, costlier, and more specialized, more geographically maldistributed, merged, controlling doctors' practices, abandoning African American neighborhoods and other minority neighborhoods, these changes are not legitimate. The more powerful these hospitals become, the more they will look out for themselves, not for us. We have to get the right hospitals in the right places. Thank you very much.
since I'm the last speaker, I think I can do this. Please join me in thanking Professor Yearby and her team for putting together this wonderful conference. So I like to think about work in health disparities as progressing through a series of 4 steps. The 4 phases. The first phase is what I call the descriptive phase, where we identify the presence of a health disparity. The second phase is a mechanistic phase, where we try to understand the causes or the reasons for the health disparity. The third phase is the intervention phase, where we try to develop and test an intervention to reduce or maybe even eliminate the disparity. And then the fourth phase is the dissemination phase, where we take our tested and promising intervention and try to disseminate it more widely. So I'd like to illustrate those 4 phases with some work that we've done on trying to address disparities in access to kidney transplantation. So here's some quick background about the topic. About 500,000 Americans have end-stage renal disease. This refers to permanent and complete kidney failure. So permanent means that there's nothing that we can do to make the kidney function come back. Complete means that the kidney function is so far gone that individuals with this condition need to either get chronic dialysis on a regular basis, as shown by this patient in the picture, or they need a kidney transplant in order to survive. Now, to get chronic dialysis, you have to go typically to a chronic dialysis center 3 times a week, get hooked up to one of these machines for 4 hours at a time. If you compare those 2 treatments for end-stage renal disease, transplantation with dialysis, it turns out that transplantation is much better. It's better in terms of patient survival, it's better in terms of patient quality of life, and it's better in terms of lower healthcare costs. But there's a severe shortage of kidneys for transplantation. At any given time, there's about 100,000 Americans on the waiting list who want to get a kidney transplant. And every year, we only do about 10 to 15,000 kidney transplants. So most people who have end-stage renal disease who want to get a kidney transplant are never going to get a kidney transplant. They're going to die on dialysis. Now, kidneys for transplantation can come from 2 sources. They can come from a living donor or a deceased donor. A living donor would typically be a relative, like a child or a spouse or a parent, who donates one of his or her kidneys to the individual with end-stage renal disease. Deceased donor would be somebody like who's been in a car accident and is brain dead following a car accident, and those individuals could donate both of their kidneys. Now, the way the deceased donor kidney allocation works is that there's a waiting list for each region of the country, and the people who are on the waiting list move up the list based on how long they've been waiting, so they get some points for how long they've been waiting, and they also get points for how well their tissue type matches the tissue type of any kidney that might become available. And the reason we do that is because just like when you do blood transfusions, you want the blood types to match. When you do kidney transplants, you want the tissue types to match as well as possible, because better matched kidneys last longer and work better. So that's everything you wanted to know about kidney transplantation. Let me go through those 4 phases now. The first phase in thinking about disparities is describing the disparities. So we looked at what the deceased donor transplant rate was in our part of the country. This is the states of Ohio, Kentucky, and Indiana. And this is the number of, this is the transplant rate per 100 patients with end-stage renal disease. Yeah, so you can see that out of every 100 white patients who have end-stage renal disease, 11 of them get a transplant. But out of every 100 black patients who have end-stage renal disease, only 5 of them get a kidney transplant. So whites with end-stage renal disease are twice as likely as blacks with end-stage renal disease to get kidney transplants. If you look at men versus women, men are about 50% more likely, if they have end-stage renal disease, to get a kidney transplant compared to women. And if you look at by income, again, rich people with end-stage renal disease are about twice as likely as poor people with end-stage renal disease to get a kidney transplant. So this area of access to kidney transplantation illustrates racial disparities, gender disparities, and socioeconomic disparities. Okay? So that's the descriptive phase. Let's talk about mechanisms. Why do these disparities exist? Before I tell you what we did, let me ask a couple people in the audience to offer their thoughts about why we see these race, gender, and income disparities and who gets kidney transplants. Any ideas? Yeah. So remember I mentioned that we want to have the tissue types match, and to some extent the tissue type matching is a little bit better within races than across races, although it's not a hard and fast thing. And if you're not having enough African Americans donating, then African Americans might be harder for them to get kidneys. So that might explain the race disparities, but it wouldn't tell us about gender or socioeconomic status, right? In the back.
Awareness.
What do you mean by that?
People being aware that kidney transplant is an option. Not everybody is aware of it.
Okay, so they might not be aware of it, they might not be interested in getting a transplant, right? Anybody else? Yeah?
There are teams that evaluate individuals for appropriateness for transplant, and the process of evaluation is not exactly scientific. It's a lot of judgment and perception, and that is affected by race, gender, and SES, and helping individuals for transplant.
Good, okay. And Professor Randall?
Access to healthcare, if your list is based on how long someone's been on the list, it would seem that the more privileged you are, the more and the better access you have, the quicker you can get on the list. And so it may be that blacks and poor who have less access to care are on the list shorter times.
Okay, good point. So it turns out that in our country we have universal health coverage. We have universal health coverage if you have end-stage renal disease. So in the early 1970s, Congress passed a law that extended automatic Medicare coverage to anybody who has end-stage renal disease. So normally we think of Medicare as health insurance for the elderly, and it is, but there's one exception to that, which is end-stage renal disease. If you have end-stage renal disease and you're 35 years old, you automatically qualify for Medicare, and then Medicare will pay for your health care just like it does if you're over 65. In other words, it'll pay for your dialysis treatment, it'll pay for your kidney transplantation, it'll pay for you to go see a doctor. It doesn't have to be even for kidney disease, it could be for any medical condition. So everybody in this sample that I'm giving you numbers for, they all have Medicare, they've all had Medicare since they developed end-stage renal disease. There might be still some other issues with access to care, but at least in terms of having health insurance, they all have health insurance.
So Medicare does have substantial out-of-pocket costs.
Sure.
Which could fit in with your findings.
Yep. Okay, so let's keep going. So what we did to try to understand the mechanisms or causes of these disparities is we tried to think about what are the steps that patients have to go through in order to get a kidney transplant. So if you're a patient with end-stage renal disease, in order to get a kidney transplant, you have to be medically suitable to go through the surgery. You have to be interested in getting a transplant. You know, if you're just happy staying on dialysis, then you're not going to go for a transplant. You have to go to a transplant center to get worked up. And in this area, there's 2 transplant centers, one at university hospitals and one at Cleveland Clinic. And when you go to the transplant center, a team of physicians and other professionals will get a detailed history from you, get a detailed, do a detailed physical exam, do a lot of lab testing, including tissue typing. They'll see if there's any outstanding medical conditions that need to be addressed before you can get a transplant. Then if you pass that transplant center workup, then either you get placed on a waiting list to wait for a deceased donor kidney to be available, or you try to see if you have a family member who's able to donate a kidney to you while they're still alive. And then hopefully eventually you move up the waiting list or you get a kidney from your living donor and you get your transplant. So these are the steps you have to go through in order to get a transplant. And we thought if we want to understand why blacks, women, poor people are at a disadvantage in terms of getting kidney transplants, let's look at how different patients move through these steps and figure out which step or combination of steps are acting as barriers to blacks, to women, to poor people. So we did a cohort study where we recruited 7,000 new end-stage renal disease patients in our 3-state region. We followed them over a 4-year period, and at the end of each of those 4 years, we figured out which of those steps the patients were at, and then we did some analyses to see which steps act as barriers after adjusting for other demographic and medical characteristics. Here are the results for movement of blacks compared to whites. The numbers over there are odds ratios that tell you what are the odds of a black patient completing that step compared to the odds of a white patient completing that step. Anytime the odds ratios are close to 1, that means that blacks and whites complete that step at the same rate. And anytime the odds ratios are significantly less than 1, then that means that that step acts as a barrier to blacks compared to whites. And you can see here at the bottom that we adjusted for other characteristics of the patients, like their age, gender, income, cause of renal failure, and years on dialysis. So let's start over here. The odds ratio for medical suitability is 0.96, which is pretty close to 1. So that means that blacks and whites are equally likely to be considered medically suitable. The odds ratio for interest is 0.68, which means if you only look at people who've already been judged to be medically suitable, then blacks are 32% less likely than whites to be interested in getting a transplant. The odds ratio for completing the transplant workup is 0.56, which means if you only look at people who are suitable and interested, then blacks are 44% less likely than whites to complete the pre-transplant workup. And then finally, if you look at the odds ratio for this last step of getting the transplant, what that means is that if you look at people who've completed all these other steps, then blacks are half as likely as whites to get a transplant. So blacks are being held up at steps 2, 3, and 4 in getting a transplant. Here's how women versus men move through this process. You can see the odds ratios are between 0.8 and 0.9 at each of those steps, and so that means that women are 10 to 20% less likely than men to make it through each of those steps. And here's the movement of poor versus rich. You can see that the odds ratios are low for the first 3 steps and then close to 1 for the last step. So that means that poor people are getting held up here, but that small subset of poor people that do make it to the waiting list, they then move up the waiting list at the same rate as wealthier individuals. Okay. So I've described the disparity, I've told you a little bit about the mechanism, and the question is how to address these disparities. So what are your thoughts about how these race, gender, or socioeconomic disparities could be addressed? Yeah.
Do early identification or make the pathways to understand, to address those barriers between those steps, maybe by looking at the existing pathways?
So try to figure out a way to make the pathways more efficient, more equitable? Okay, good. Anybody else? Well, let me tell you what we did. We decided to use navigators. Navigators are trained lay people or health providers who can educate or assist patients go through a complicated healthcare regimen. They've previously been used successfully to promote cancer screening and cancer treatment, but not so much in other areas. And we actually thought that we would use kidney transplant recipients as navigators for other patients, right? Kidney transplant recipients are people who have the shared experience of end-stage renal disease. They've already gone through the steps and gotten a transplant themselves, so we thought that with some training that they would make ideal navigators for other patients with end-stage renal disease. So we did a randomized controlled trial where we randomized dialysis patients into 2 groups. One group had kidney transplant recipients who were navigators meet with them on a regular basis. They met monthly with the dialysis patients while they were getting their dialysis treatments. The navigators provided information about the transplant process to the patients. They figured out what step the patients were at and then helped them move forward to the next step. Basically, they acted as a source of support and help, but they weren't pushy about it. So if somebody just wasn't interested in transplantation, they didn't keep persisting. And then we had another group of dialysis patients that were randomized to a usual care group that continued to get care from their kidney specialists and from their dialysis facility staff, and part of that care is supposed to involve education and assistance with the transplant process. We followed both groups for 18 to 24 months, and our primary outcome was the number of steps that were completed. In other words, we looked at what step the patients were at when we started our trial, what step they were at the end, and we just subtracted and figured out how many steps each patient had completed. Altogether, we recruited patients from 23 dialysis facilities. There were 92 intervention patients, 75 control patients. At baseline, they were similar in their demographic and medical characteristics. At the end of our trial, you can see that on average, the navigated patients completed 3.5 steps. The control patients completed only 1.6 steps. So the navigated patients got twice as far in the transplant process compared to the usual care patients. And this is very important, I think, also, is that the results were similar by race, gender, and socioeconomic status. In other words, navigators were just as helpful for white patients as they were for black patients. They were just as helpful for men as they were for women, and they were just as helpful for poor people as they were for rich people. Let me just give you a quote from a patient who was in the navigated group to illustrate the patient's perspective here. This patient said, "Several people had talked to me before about transplant." He's referring to his doctors and the dialysis facility staff. "However, I was never interested until I met someone who had actually been on dialysis and had a transplant, namely the navigator. Sharing your experience with me is what changed my mind." Okay, so I've described disparity, told you about the mechanism, told you about a promising intervention. How would you now disseminate this intervention? Anybody? I only have 1 minute left here.
You get navigators in every situation.
Sure. So now this project that I just described was funded by an NIH grant, and we paid the navigators full-time salaries as if they were research associates, which we considered them to be. So we paid them $40,000 a year, and another $10,000 was for benefits. So we need about $50,000 per navigator to do this. And in fact, what we did is we went back to NIH and we asked them for a dissemination grant, and we were lucky enough to get that. And so now we're disseminating this navigator intervention to 3 Midwestern states. We're actually going to have the transplant centers hire the navigators who we'll pay for from our grant. We're going to nearly eliminate all the research data collection so navigators can really just focus on helping patients and not worry so much about collecting research data. We're going to give them some flexibility in how often and in what ways they interact with patients. And instead of looking at patients going through those steps as the outcome, we're going to actually look at the very end of the process. We're going to look at wait listing and actual transplantation as the outcomes. So to summarize, we found that there's multiple complicated steps in the transplant process, that disparities exist in completing these steps, and that navigators are a promising approach to help patients through the process. And finally, I'll put up this slide, which gives you some information about our Health Disparities Center. We're involved in a number of research, education, and community collaboration activities, and there's our contact information if you have any other questions or if there's anything we can help you with. Thank you.
We have time for 2 questions. Any questions for our panelists?
I'm interested in. So I'm really interested in the way that the navigators helped with the steps after the piece where they got patients interested in that. So can you say more about that? I mean, I'm interested in like Aanian's work, and then there's a lot of anecdotal work talking about what happens once people get on the wait list, and then when do they actually get the kidney, when they get it once available. So how do navigators help with that part?
So the first thing the navigators did was figure out what step each patient was at and what seemed to be preventing the patient from moving forward. and then they tried to work on that specific task. So for example, if someone wasn't interested in a transplantation, then the navigator tried to figure out, well, were there any misperceptions about the benefits and risks of transplantation that could be addressed? If a patient was having a hard time getting to the transplant center to complete the transplant workup, which actually involves several visits, then the navigator would find out what the issues were. Were there transportation issues, job issues, babysitting issues, and we try to help the navigator deal with that. Once the patients did get on the waiting list, then there are certain activities that the patients have to do in order to maintain their active status on the waiting list, and so then the navigators would help with that. So really it was an intervention that was tailored to the unique circumstances of each patient.
So the piece between staying on the wait list and getting the kidney, that piece might still have a gap, potentially.
Yeah, that wasn't, I mean, we couldn't, as part of this project, create a bigger supply of deceased donor kidneys for transplantation. But one of the things that the navigators did do is encourage patients to look within their circle of relatives to see if there might be a suitable living donor, and then we coach them in how to talk to those individuals. So we did think that we were able to slightly increase the pool of potential living donors.
Okay, right up front.
Is the race, sex, or socioeconomic status of your navigators relevant? And did you make any attempts to, if I'm a patient, set me up with somebody who seems like me?
Yeah, that's a good question. So this was a small study, and we had 3 navigators. We had 2 African-American navigators, 1 white navigator. We also had 2 women and 1 man. We didn't specifically try to match them up. It didn't seem when we analyzed the results that it really made any difference.
I know there was a hand in the back.
I had the same question that was just asked.
All right, great. Well, Professor Yearby?
I'd like to thank the panelists for a wonderful panel. So, what is going to be different about this breakout session, right? This breakout session is that you have identified your solutions as we did last time. So what are the next steps? What do we need to do? They can be broad, right, in terms of we need different legislation. They could be very focused in terms of we want to begin to meet with communities, okay? That we want to identify people who will talk about this issue. But we want to leave with action steps and plans for where we need to go, okay? And again, I am collecting the forms before you leave, and we'll make available the forms that you filled out in our discussions. As I said, I will email everybody, but there will be an archive of this. But that as we take this power, as we listen to the knowledge that we need to do something other than, for me, in my heart, just publish papers. I love papers, but we need change. And so this group, you just know you're getting called. And so let's go ahead and meet together. Let's meet for, let's say, 1:55, and then come back together and report. Okay? Same groups as last time. Thank you.